School of Pharmacy and Pharmaceutical Sciences at Cardiff University in UK. She has PhD in Chemical Engineering from Loughborough University, Master in Physical Colloid and Surface Science from St. Petersburg State University, Russia, and Bachelor in Chemistry from St. Petersburg State University in Russia. Her current research projects are on target drug delivery for joint diseases, anti-inflammatory drug delivery systems to prevent wear particles induced inflammation, orthopedic antimicrobial nanocomposite bone cements, multifunctional hydrogels as bone graft materials, and nanomechanical and surface properties of cells post-exposure to metal, ceramic, and polymeric wear particles. Polina, it's a great pleasure to have you here, sharing your knowledge, sharing your studies. Please feel free to have your presentation. And after the presentation, we will open for questions, okay? So, thank you very much.
Thank you. Thank you, Karina. Thank you, everybody. It's a pleasure to be here in Unicamp again. And here we start. Okay, in my lab, I run multidisciplinary laboratory. In my lab, we start from fabrication of nanomaterials, starting from the small molecules, going to the micro level, and from nano micro level to the bulk materials. We do full characterization of the materials, such as size, charge, distribution, ratios of organic and inorganic matters. We looked at the molecular weight because we work a lot with the polymers. We synthesize novel polymers and use them for preparation of our materials. We also do a lot of functionalization of materials. Either it's development of new materials or using novel coatings on already existing materials. And once we prepare and functionalize our materials, once we're happy with their integrity and material properties, we also do a series of in vitro and ex vivo experimentation. Depending on application, if it's a wound healing application, antimicrobial, or materials or treatment for musculoskeletal diseases such as osteoarthritis. We work a lot with antibiotics and non-antibiotic small molecules. We change them, so giving them a new properties and new functionality to enhance release of existing drugs and enhance the efficacy for the specific site, for the specific disease. We also develop functional nanocarriers for effective drug delivery. And we work with small anti-inflammatory molecules and biologics as well. So, background. Why a lot of my research in my group is dedicated to treatment of musculoskeletal diseases. Specifically, we focus on osteoarthritis. Why we have chosen to work in this area? It's just because it's a big problem in a society everywhere in the world. It's affected 1.7 billion people worldwide. Bone, back, and joint pain disorders, they cost European economy a lot of money. It was estimated it costs 200 billion each year. And it's also primarily because of absenteeism from work, which is estimated, according to the Office for National Statistics, it's 31 million days work lost per year. But it's not only a problem for UK or Europe, it's also a problem worldwide. So it's a big problem which is worth investigation. Also, apart from that, without specific treatment, Musculoskeletal diseases, they are likely to develop long-term chronic conditions and associated with a severe pain, and also other diseases, mental diseases comes into play, such as a risk of depression. In this specific arm, we targeted specific areas. So we developed functional drug delivery systems to treat joint diseases. We looked at the dental and orthopedic antimicrobial nano-composites bone cements to target this area. And also we looked at the delivery of anti-inflammatory small molecules and associated functional carriers to deliver the specific drugs to prevent wear particles induced inflammation. So this is the first part of the presentation, drug delivery in a cartilage. So, just a little bit of background for you. Perhaps not everybody knows what is cartilage. Cartilage is a connective tissue. It's found in many areas in our body. We have cartilage between our jaw, between our bones, in elbows, knees, ankles, and of ribs, ears, nose, bronchial tubes, between vertebrae in the spine. There are different types of cartilages exist in our body, but specific for my research, we focus on articular cartilage. Articular cartilage you can find in your ears, nose, and joints between bones. In bronchial tubes, there are different types of cartilage exist. So what is articular cartilage? It's, from material point of view, it's low friction, wear resistant tissue, which presents between joints and helps the joints tolerate any stresses and pressures associated with everyday activities. It's very strong tissue, rubbery tissue, very flexible tissue from material point of view. However, from biological point of view, this tissue is challenging. Challenging in terms of if it's damaged, it's very difficult to regenerate. This tissue has got very poor regenerative capacity. So let's look at the structure of the cartilage. Cartilage has got a network of collagens with proteoglycans, and there is only one type of cell exists in cartilage. They're called chondrocytes. There are no blood vessels, and if you can imagine, when there are no blood vessels, delivery of drugs could be very, very challenging for this specific tissue. In cartilage diseases, there are two types of diseases we can differentiate. One is rheumatoid arthritis. It's a chronic autoimmune disease, and it's affects the joints of people. When joints become inflamed, they cause pain, swelling, and stiffness. So people have to live with rheumatoid arthritis for the rest of their life. And there are management symptoms of disease exist, but still there is no specific cure for rheumatoid arthritis. And there is another disease called osteoarthritis. When we know a lot about rheumatoid arthritis today, we still don't know that much about osteoarthritis. That's why when we look at these two diseases, there is a lot of research in the area of osteoarthritis exist. Still in an area of discovering new molecules, new drugs to treat osteoarthritis or deliver effectively existing drugs. So I already explained you what cartilage is. So osteoarthritis is a disease of articular cartilage. What happens with our everyday activities, our cartilage gets worn, can get torn apart, and eventually it's lose functionality. So we can call it bone against bone joint motion, which leads to the thinning and reducing functionality of articular cartilage. It's a disease of wear and tear. That's how biomedical engineers would call osteoarthritis. If you would talk to biologists, to bone biologists, they would not agree with you. They would say osteoarthritis is a disease of the whole joint. And I will explain you later on why. So just a little bit of statistics just to reinforce why this is still important to study osteoarthritis. In the UK, it affects 8 million people. There is no disease-modifying drugs for the treatment of osteoarthritis found to date. Current treatments, they rely on a management of the pain and inflammation. So it's not a treatment, it's a management of the disease. And total joint replacement is the last stage of a treatment. It's a massive operation for the late stage of patients with osteoarthritis when there is no any more cartilage left between your joints, and patients, they struggle to move their joints, they struggle to perform everyday activities. So the only stage, the only option for them remains is a total joint replacement. So let's look now on the pathology of osteoarthritis. So here you can see osteoarthritic joints and healthy joints. And you can clearly see the damages which happens with the cartilage in osteoarthritic joints. So the cartilage is torn apart, it's in pieces. There is no smooth lining of the cartilage like in a healthy joint. The thickness of the cartilage with the patients with osteoarthritis also changes. And this disease also moves to the synovial fluid. It affects the whole joint, this space between the bones. And the cartilage degeneration also affects the underlying bone as well. That's why biologists call that the disease of the whole joint. It's not only disease of the cartilage. So I already mentioned to you that today there is no drugs available for the treatment of osteoarthritis. And mostly it's only management of the disease, of the symptoms of the disease exist using anti-inflammatory drugs, which patient has to do it for the rest of their life to be able to perform everyday functionality. So also the delivery of the therapeutics is very challenging because there are no blood vessels in the cartilage. It's avascular tissue. So the only delivery of drugs, it's currently performed in clinics through intra-articular injections. It's a very painful procedure. It has to be performed by the doctor, not by the nurse. And nevertheless, once the drugs injected in intra-articular space, they will clear very rapidly from that space because there is no retention of the drugs exist. So, coming to this point, development of effective delivery system to deliver effectively current drugs available for the management of the symptoms of osteoarthritis, and perhaps a new generation of drugs which is intended for the treatment of osteoarthritis, a very urgent need to be able to do it. So now we come to the technology which we developed in my research group. We patented that technology. This patent has been granted. It has been granted in the UK and in Europe. And it's so-called polyplex-based drug delivery system for the cartilage. Our target was to improve therapeutic efficacy of the drugs, deliver them effectively, avoid any off-target effects, such as side effect of these drugs, and also have effective targeting pathology of the disease. How did we do that? We took advantage of the structure of the cartilage matrix. If you remember, in a few slides before, I showed you that cartilage has got a lot of proteoglycans. They're highly negatively charged molecules, biomolecules. And we developed Polyplex, which is highly positively charged. It's a biocompatible material, highly positively charged. And using the magic of chemistry, we conjugated specific drugs to the branches of our polymers. So in this case, we play a lot of anti-inflammatory drugs, which is currently used for the treatment of osteoarthritis. And we also managed to conjugate some of the biologics as well. So what we wanted to achieve? We wanted to achieve higher uptake of the drugs within the cartilage and higher retention of these drugs in cartilage. Our objectives also were to show the cartilage penetrating ability of polyplexes, to determine uptake and retention of specific drugs. We use initially dexamethasone as a model drug because it's widely used in clinical practice currently for the management of the symptoms of osteoarthritis. And we also developed ex vivo early stage osteoarthritis model. It's called GAG-depleted cartilage. And we wanted also to demonstrate that in GAG-depleted cartilage, we could achieve high uptake and high retention of the drugs using our polyplex systems the same way as in a healthy cartilage. You would ask me, why did I do that? Just because our technology relies on a highly negative charge of proteoglycans, of GAGs, yes? So if in early stage osteoarthritis, there are less GAGs than in a healthy cartilage. So our hypothesis was, would our technology still will work for the early stage osteoarthritis? Yes, you will see it later, it does work. And also we looked at the cytocompatibility of our polyplex system towards the only cell which is available in cartilage matrix, chondrocytes. So this is just properties of our polyplex systems. It's a class of the copolymers, so it's not only one polymer, it's a class of the copolymers. They're highly biocompatible, they're highly positively charged, they're biodegradable, and they're low cost. So it's easy to scale up and to synthesize them. This is experimental setup which we had. We developed it ourselves as well. So it's based on one diffusion system. In one side, we had our polyplex with drug formulation. Another side, we had a media. We use HEPAS media. And this is the cross-section of the cartilage matrix. It's a bovine cartilage, very immature cartilage from 7 days of young cows. So what we did, using this experimental setup, which previously demonstrated, we synthesized different polymers out of the family of the polyplex family, and conjugated dexamethasone to all these polymers. So we had around 60 plus structures. There are some, not all of them, but most of them which are working, they're presented here. Almost all these structures, they work in terms of uptake, enhanced uptake and retention of the dexamethasone in a cartilage matrix. As you can see here, the uptake is increased by 7-8 times compared to the commercial formulation, which we use as a control. And only some structures did not work with that well. They still were preferential compared to the commercial formulation. They still give enhanced uptake, but not as significant as some of other formulations, as you can see in the beginning of this graph. We also wanted to make sure that our polyplex system can go through the cartilage tissue. So we wanted to ensure that it doesn't really stay on the surface of the cartilage, superficial zone of the cartilage. It goes through the whole depth of the cartilage material. So we did measure diffusion coefficient, and by fluorescent labeling our polyplex delivery system, we did show that our nanosystem is able to go through the whole depth of the whole thickness of the cartilage material. Also, we question aspects. Is that important conjugation by itself, or we can do as a self-assembly of dexamethasone with our polymers, and it would be the same results. And the result shows that it is important. Conjugation is really critical for the system, because if you do not have a conjugation, your self-assembly is not as effective as a conjugated structures with the polymers. Another thing, so far we showed you results on one model drug, dexamethasone. So we start doubting, is this is only dexamethasone works so effectively? What about other drugs? We wanted to show the cargo agnostic properties of our system, because it was very important for our patented attorney. They told us, if you only have one drug, you can have one molecule which you can patent. If it works for many molecules, and you have many polymeric systems within the class of poly-X which works, so you can patent the whole family of that. And that's what we have done successfully, because we showed the efficacy of other drugs such as ketorolac and prednisone on improved uptake and retention compared to the commercial formulation of these drugs using our nanoplex systems. And finally, we wanted to make sure that our poly-X, they're cytocompatible to chondrocyte, so that the cell viability and cell proliferation is not suffering once we incorporate the poly-X system into our formulation. We did do MTT and LDH classical viability assays to prove that, and we did prove that polyplex system does not give any adverse effect in terms of cytocompatibility towards chondrocytes. So in summary, we demonstrated that our poly-X, they constitute effective drug delivery systems for cartilage. It's a cardio-agnostic system. It can deliver any drugs effectively towards cartilage, and also not to only deliver, but also can retain that for prolonged period of time. The covalent bonding is very important, is essential to achieve targets in delivery system. So only self-assembly is not enough in this case. And also, we show the efficacy for the early stage of osteoarthritis using GAG-depleted cartilage, because even if you reduce amount of GAGs, proteoglycans, in our cartilage tissue, we still can achieve effective uptake and retention using our system. So if we still in the future work, so we're currently doing ex vivo experimentation to show the efficacy of the system in animals, simulating early stage of osteoarthritis, and we're still working with optimization of our formulation as well. So before I move to the second part of my talk, if you have any questions for this part, I would encourage you to ask, because otherwise it will be too difficult for you to follow. Yes. Mr. Tracis, yes. How they develop this disease?
Yes, yeah, it's genetic things, or you gain by living, you know?
Most of the osteoarthritis is gained by living. Usually osteoarthritis is disease of elderly population. People get that, or many people get it after 60 years plus. It depends, there are some confounding factors such as obesity, diabetes, which could increase risk of developing osteoarthritis even early. There are also trauma. Many sportsmen, they develop osteoarthritis with time, very young. You know, you can have osteoarthritis even when you're 40. just because your cartilage gets completely destroyed. So if you don't have any cartilage, so you obviously will have osteoarthritis. So it's, there are, I'm not a biologist, but I've been working with biologists for many years. There are some genetic kind of domination of that as well as a factor, but most of this disease is happens with time, with life. It depends on your habits as well. So if you, for example, running is very good. We all want to stay fit, but if you run too much, you can destroy your cartilage very rapidly. And you know, after 40 plus, you might not be able to run anymore. So it really happens a lot with the sportsmen and with very active people. But also it happens with people who are not very active at all. Just because of the obesity and lack of exercises, you still will destroy your cartilage with time. Thank you.
And it's your first work. It's your first. May I have another question?
Yes, yes.
It's your first. It is your first work working with polyplex, or is just the thing that you usually do?
For the cartilage things, we've been working with polyplexes for, I think, for the last 7 years. We use them. This is one application for delivery of small molecules for the treatment of osteoarthritis, but we also work with them to do functional coatings on materials, so on implants, such as dental implants, orthopedic implants. We also deliver anti-inflammatory molecules using polyplexes, so it's a different formulation, but we do use polyplexes a lot. Just recently, we started working with a cancer biologist in delivering effectively drugs who can treat cancer using polyplexes. Welcome.
Hello. I have a question. Do we have like some drugs or some treatment which can prevent the osteoarthritis in these cases? For example, your work is just when the disease is more advanced, or can we have drugs or treatment that can prevent the osteoarthritis? For example, for athletes or people who have genetic markers who can, like, you know,
Yeah.
see if you develop this disease. Thank you.
There is not much in terms of drug research for prevention of osteoarthritis. The only what doctors would recommend is it helps you do exercise and take care of your knees. But also, if you happen to develop osteoarthritis, and if it's an early stage, so to slowing down this progress of osteoarthritis, you know, to make it worse, there are different techniques available, like stem cells, for example, to help to regenerate the cartilage tissue. Also, delivery of anti-inflammatory molecules. It does help to, with a good diet as well, and you know, sensible exercises. It does help to manage the disease effectively for some period of time. But it depends on the body, you know, it depends on, there is a lot of research about pain. Some people can tolerate pain better than other people. And people with the same kind of grade of osteoarthritis can be more functional, more mobile, just because they can tolerate pain better compared to other people. So in Cardiff, we have a big group which spent the entire research on researching pain, how pain occurs and how people react to the pain. It's not my area of expertise, so I cannot say anything about that, but mostly it's a physiotherapy. This is the way of treating, managing early symptoms of osteoarthritis, sensible diet, sensible exercises. And when this when people cannot tolerate pain any longer, the delivery intraarticular injections of of anti-inflammatory drugs is the option. There are other options, is delivering intra-articularly as well, different molecules, such as biologics, like hyaluronic acids. So what it does to cartilage, it reduces the friction between the cartilage and the bone because it works like a lubricant. And because it's relatively viscous liquid, viscous fluid, it can stay in the boundaries between the cartilage and the bone for a long time. So it's kind of protects your cartilage from further damage. That's another thing, and it's widely used in clinics. Okay.
Thank you, Polina. Any more?
Hi, I was wondering if your research group already thought about how to do the administration if it became a medication, if it should be an injection locally or if it's stable by oral administration. I was just thinking about it.
It's fine. So the problem with the oral administration of the drugs is you have to deliver high concentration, almost like toxic level concentration of drugs to be able to achieve the therapeutic level into cartilage. Because of the problem, there is no blood cells. Yeah, it's very little what you get orally comes eventually towards your cartilage. So the effective treatment, it's a local delivery through intra-articular injections. So it's basically the needle goes in an intra-articular space between your bone and cartilage and deliver the formulation that way. So it's a very painful procedure, and our system has been developed for intra-articular injections. So in vivo experimentation, which we are doing currently on rats, it's we use osteoarthritis, early stage of osteoarthritis model, and we deliver the formulation intra-articularly way. It's painful. It has to be done only by doctors, so it's not something which you can have like needle, for example, stuck somewhere else. It's because the space, this intra-articular space, is very narrow, so you have to be very well trained to do it exactly, precisely in that space.
Hi, I was wondering if the drug that you will conjugate to the polyplex has to have any requirements, or it can be any kind of drug?
It could be any. So far, we use different drugs and biologics. It could be, well, if you give me a new molecule, I could think about that. So how I could conjugate, but so far what we made conjugate is quite large variety of drugs with various properties. The things which is requirement, it has to be connected through the ester bond. We need to have ester bond because that's the way how a drug gets hydrolyzed once it's reached cartilage and released into the cartilage matrix.
Thank you.
Anyone else? I think it's okay, Polina.
Thank you.
Can continue.
We'll continue. So this is the second part of my talk. Well, I think it is the second, but I have a third one as well. That's all right, but it's connected. It's delivering of antimicrobials using nanotechnology to orthopedic bone cement, but we also collaborate with Karina on delivering antimicrobials through nanotechnology to dental cement. So it's not only for applicable for orthopedic bone cement, but also for dental bone cements as well. Oh no, yes, that's fine. Apologies for that. So this is a bit of introduction as well for your benefit. What is cement? You would ask me. Remember I was telling you that end stage of osteoarthritis, it's a total joint replacement. So basically when the bone gets cut and replaced with an implant, with artificial implant. So you can imagine here you have implant, and this is your real bone. And this is interfacial space between implant and bone filled with cement. So there are two types of surgery. There could be cemented joint replacement and uncemented joint replacement. There are pros and cons for each type of surgery. With the uncemented joint replacement, you need to have quite young bone, good quality of bone, and it's usually recommended for young patients. When we say young patients, it's 60 plus. But as I said, there are joint replacement done on a much younger patients because of the trauma or some other conditions happening in their life. And cemented joint replacements usually performed on elderly patients, so it's 80 plus, because the quality of their bone is different already, and they are less mobile compared to the younger group of patients. So cemented surgery is appropriate for them. So let's think about what is the problem with infection and why we need to deliver antimicrobials through bone cement formulation. Usually, it's up to 5% after surgery. So it could be joint replacement in a hip or knee. Patients, they develop infection. And there are different stages of developing infection. Some patients that develop infection within the next 10 days post-surgery. Some patients that develop infection within the first months post-surgery. And some they can develop infection even after 6 months post-surgery. And obviously, like in the beginning, when patients are treated with antibiotics, oral administration of antibiotics, 2 weeks before the surgery and 2-3 weeks after the surgery to prevent infection, the risk is much low. But once antibiotics are done their role, after the first month, the second month, there is no more prevention or the prophylactics of infection, and that's where infection can occur. So there are different types of treatment. It's a 1 stage of surgery or 2 stages of surgery. Obviously, when the operation needs to go into 2 stages, so the risk of infection is much higher. And current, as I said before, current prophylactics is systemic administration of antibiotics, or delivery of local antibiotics through antimicrobial bone cement. This is the bacteria which predominantly found on surgical sites: Staph aureus, Staph epidermidis, MRSA, Acheta baumannii. They are the classical, widely found bacteria. The risk of infection gets even higher when the patients need to undergo revision surgery. What is the revision surgery? If the first surgery was not successful, for example, could be different reasons, could be infection again, could be aseptic loosening, when the body is not accepting the implant, could be mechanical problem, dislocation of, for example, of the hip, so the pain which patients experience after the surgery, continuous pain. So the surgeon needs to remove the current implant and go through the revision surgery. So it's a second surgery. And obviously, that surgery is much longer, and the risk of infection is much higher. Of course, you think 1 to 5%, it's not, a high percentage enough. Yes, but with infection, you either get cured or you can die. So it's no any other kind of in between. And the cost of the joint replacement surgeries are very high. For UK, it's estimated between 10,000 and 20,000 UK pounds, just including the surgery for 2 weeks hospital stay. So obviously, nobody wants to come for the revision surgery. Everybody wants to make sure that the first surgery is successful and they can go home as soon as they can. So what currently is done in surgery? They load antibiotic powder without any carrier in a bone cement formulation. They mix it within 3 to 5 minutes in operating room just before applying that during the operation on the patient. So there are specific requirements which this cement material has to fulfill. They have to have specific mechanical strengths, mechanical properties, ability to flow, thermal stability, and elution for a long period of time. So when we develop the new material for this application, we have to be very, very careful that our drug carrier is not influenced, is not interfering on any of these properties. Because if it does, it will not be used in clinics. So currently, what is used in clinics, it's give less than 10% burst release. So 10% of antibiotics is released, and a lot of drugs is remain within the bulk of the material. So it does not give you prolonged antimicrobial efficacy. The antimicrobial protection is only for the first 1 week. And after that, obviously, when there is no more elution of antimicrobial drug is happening, patients is prone to infection. So what we would like to achieve in our research, we would like to have prolonged effective delivery of our antimicrobials for the required period of time in a controlled manner. You would ask me, what is the required period of time? We talk with the surgeon, with the clinicians, and for specific orthopedic application, they wanted us to deliver at least for 1 month antimicrobial drugs. So our approach, we use silicon nanoparticle and load them with antibiotics to control or extend release of the antimicrobials in polymethyl methacrylate bond cement. As antibiotics, we use gentamicin because it's widely used currently in clinical practice. It's our model drug. And why silicon nanoparticles we use as a carrier? It's very well researched in the literature. It's widely used for various biomedical applications. Silica currently already used in for topical applications. It's used in some of the, for example, ceramic, in some of the medical devices as well. So it's safe to use. It's also easy to synthesize and easy to scale up at very low cost, which is very important. So we did conjugation through subbaric acid, our antibiotic, to amino-functionalized silicon nanoparticles. We also use different techniques, not only conjugation. We look at the entrapment of the antibiotic molecule at the stage of preparation of silicon nanoparticles, absorption of the amino-functionalized silicon nanoparticles, our antibiotics, and absorption in the presence of subbaric acid as well. So once we prepare all these different formulations, all these different nanoparticles, we looked at the size, shape, composition, and the ratios between organic and inorganic matter, just to ensure that we do not have variability from batch to batch in our nanoparticles preparation. So, and finally, this functional experiment, we did release. We did release of gentamicin into PBS media from our nanoparticles. And as you can see here, you have controlled release for a few days in case when you have conjugation and when you in case when you have entrapment in the presence of subbaric acid. When you have just absorption, you do not really have that much release. Well, you have release, but it just happens in the beginning, and after this it goes on a plateau. It's also pH, as you can see, influence on release, because obviously pH 7 is a neutral pH. When we have an infection, our pH drops. So we wanted to simulate what will happen inside when we have infection. So release changes as well. But it's not impressive release. We wanted to achieve much longer and more controlled. So we wanted to change our strategy. And we did change our strategy. We used different technology. It's called layer-by-layer deposition or layer-by-layer assembly. So what is the principle of that? So when you prepare your silica nanoparticles, you amino-functionalize that in amino groups. So you give your positive charge to your silica nanoparticles. And after that, you start creating layers on the top of that nanoparticle. Yeah? And it's based on electrostatic interaction. So if your first layer is if your nanoparticle is positively charged, so your first layer has to be negatively charged. The next layer will be positively charged, etc., etc. And we can entrap our small molecules, in this case gentamicin, between these layers. And that's what we achieve. On amino-functionalized silica nanoparticles, our first layer was alginate. It has got zeta potential of around minus 40 millivolts. And after that, we put gentamicin there. It doesn't have great charge, but we still want to entrap that. And the next one, you asked me if I use polybit poly-X somewhere else. Yes, we do use poly-X, one of the molecules, 2 polymers of the poly-X family in this layer by layer deposition. It's called A1 and A2. And we use it as a positively charged polyelectrolyte. So this way we can create as many layers as you want. It's highly labor-intensive job. Just recently we purchased a machine, so we can do 100 to 100 layers, but before it was a highly intensive job for the students. So they were creating 80 layers, and it was taking them a few days to do it. But it was worthy. It was worthy because you will see the release from the system in a minute. So another aspect when we do this layer by layer deposition, we wanted to ensure that our zeta potential changes when we create the layers, yeah? So because we have to make sure that our next layer sticks to the nanoparticle. That's why we have, every time when we put one layer, we measure zeta potential. Okay. Okay. Stuck. Maybe the batteries. Okay, yes, fine, it's fine, it's fine now. Yes, yes, it's moved. Yeah, it's maybe the batteries here. Yes. Thanks so much. Oh my God, that's all right. No, one more. Okay. Yeah, we'll stick here, that's fine. Yeah, it's all right. Okay, now we're on the right slide. So we did characterization of these nanoparticles as well. We looked at the organic and inorganic matter using thermochrometric analysis. So just to make sure how much organics we have increased at each time when we put extra layer to the sample. We didn't do after each layer because it's very much time consuming and it's expensive to do. So we just did it for amino-functionalized silica nanoparticle, and after this when we put the one layer, well, it's not one layer, it's a one quadruple layer. So it means 4 layers. Q1 is a 4 layers. We measure the organic content, and after this we put another 8 layers, and we measure the organic content, etc., until we reach Q10 is a 40 layers, and we measure the organic content. And this is the results which we really wanted to have eventually. So we did release from these nanoparticles over a period of 1 month plus. And as you can see, in all formulations which we prepared with a different combination of layers, we have control release, prolonged release over a period of 1 month. So we did achieve our target, what we wanted. Our clinical collaborators were very, very happy with the results. So the next step, we also wanted to see the antimicrobial activity, because if we have release of antimicrobial, it does not mean that it's enough to combat infection. So what we did, it was non-traditional antimicrobial test, but it's effective test, and now it's in protocol and standardized. So after each day, we took a browse of our, we put our nanoparticles for release in PBS. After each day, we took that PBS and we looked at the, and we put it in contact with a specific bacterial broth to see in terms of growth or not growth, in terms of antimicrobial effect. And as we did control as well, so GS is a standard formulation without nanoparticles. And as you can see here, in all cases, we do have antimicrobial effect, in some cases up to 25, 23 days, in some cases less, but still much longer compared to the commercial formulations. So there are different types of bacteria. Some of them, they are clinical isolates found in patients with infection post-orthopedic surgeries. Yeah, and also, of course, we wanted to know if our bone cement is as effective, at least as effective as a commercial bone cement. The typical cells which found in orthopedic side, the osteoblasts. So we looked at the cytotoxicity of our new materials towards osteoblast. So again, we did on a calcium production assay, alizarin red, because it's very important, production of the calcium by these cells, and also cytotoxicity as MTTSA. So we did not have any changes in terms of these two tests of efficacy compared to commercial formulation. So we're happy to proceed. And the next testing which we did is looking at the mechanical properties. So remember in the beginning I told you that you can have wonderful antimicrobial activity in your bone cement, but if mechanical properties are not within the standard, we use ISO standard, so it has to be variability within 20% maximum from the commercial formulation. This cement will never be used in clinics, because mechanics is very, very important for high-bearing operations such as knee or hip. We did look at the compression strengths, we looked at the bending strengths, bending moduli, and fracture toughness. We did measure all these and compare it with the commercial formulations. And it was in a good agreement, so within the 20% difference. So we're very pleased with that. We also looked at the stability. So we looked at what happened with the bone cement once it's immersed in a biological fluid for the period of 3 months. Because obviously, with the swelling of the cement is a porous material, with the swelling of the material, you would think that mechanics will drop. We will expect that. It did drop, but it did drop within the ISO standard limits. So it was still within the limit, which was good. So in conclusion, so release of gentamicin from PMA bone cement can be extended using silica nanoparticles, as has been shown above, using layer-by-layer deposition technique. And this release depends on a construct, on layer-by-layer construct, on a nature of a poly-X used as well. So we did not show any detrimental effect of new developed materials towards cytocompatibility, mechanical strengths, or rheological properties. I think I will continue because I have a short one, and we can have more questions. Yeah. Yeah. Thank you. Okay, so here I just want to demonstrate you some of the. It's also the technique developed using layer-by-layer deposition. So we use silica nanoparticle as our model construct. But instead of using antibiotics, we use non-antibiotic antimicrobial, example of chlorhexidine. And we did encapsulate that within our layers. So again, I will be brief because the experimentation is similar. We'll look at the organic content using TGA techniques. And we looked at the release. Here I will stop because as you can see, with the chlorhexidine, you have much longer release. In some cases, your release can reach 80 days. So it's quite impressive. So there is something with chlorhexidine. What our hypothesis is, the charge of chlorhexidine is higher compared to gentamicin. So electrostatically, it retains within LBL construct better and for long period of time. That's why we have such a control release. So here, in conclusion, I would say that layer-by-layer deposition is a suitable technique to control release of antimicrobial agents. Example from silicon nanoparticles, but we could have other model carrier as well. In case of chlorhexidine, it was for 80 days. And poly-X as a polycation polymers, they can be used for the preparation of a chlorhexidine-releasing silicon nanoparticles successfully. I have the third part of my talk as well. It's about delivery of anti-inflammatory molecules. So I wonder if you would like to listen to that, and after this, ask questions, okay? Because it's short. No, that's fine. Thank you. So here is a similar story, similar disease. We talk about joint replacement, but another problem. It's not infection anymore. It's aseptic loosening. And aseptic loosening, it's a bigger problem. So it affects between 30–40% of the patients which undergo joint replacement surgery. And also it increases risk of revision surgery after 10–15 years because of aseptic loosening. So let's think what is aseptic loosening and how we can combat that. Aseptic loosening, let me talk through some of the basic. So when your implant just got implanted, when you just got implant after operation, little bit of inflammation is a normal. So it's a normal reaction to your body to the foreign materials. But usually it stops after a few days. So it's the first stage and it's normal. If it's continuous, if it's inflammatory reaction is continuous, so it means that your body is not accepting this implant material. So there is something wrong and you have to ring the bell. This inflammation could move even for a long period of time and become acute phase. So what it means, and it comes with a long time. Because during normal, initially you would think my implant was good. So after 3 days after surgery, I was able to walk. I kind of come back to my normal everyday activities. I'm very happy. But after 5 years, you might start having problems with your implant. And you wonder what's happened. It's happening that during your everyday activities, depends how you use your implant, how you use your body. If it's, you do a lot of running, a lot of jumping, a lot of exercise, your implant gets worn. So they release nanoparticles. To start with nanoparticles, after this they release microparticles and bigger particles to the surrounding tissue and synovials as well. And this triggers inflammatory reactions. So, of course, there are macrophages here, but there are also other types of cells which start not liking it, these foreign materials, such as osteoblasts, fibroblasts. They start suffering from the toxicity of these implant-releasing particles. And that's what, when your inflammation moves to acute phase. So it's really inflammatory response, which lasts for a long time, and you have to manage that. You have to do something about this. The typical strategy is, of course, taking anti-inflammatory drugs. So what we did for our research is delivering the same way as we deliver antimicrobial drugs, but in this case we deliver dexamethasone, anti-inflammatory molecule, through layer-by-layer deposition. But we did not prepare any particles. I show you some particles as well, but we moved to the stage of already making these coatings on an implant. So we created the coatings containing dexamethasone on bulk materials. And here, again, we look at the release of the dexamethasone through time, over a period of time, and it depends on numbers of layers and the pH. This release changes, but still you have controlled release for a period of 25 plus days, which is good. It's a good news. Also, you would ask me why we use pH 6. pH 6 is a typical pH which happens when inflammation occurs in your body. And my PhD student Melissa, she developed in vitro inflammatory model treating cells with LPS. So LPA, if you treat cells with LPS for some time, it triggers inflammation or inflammatory reaction within the cell. And we use different markers such as nitric oxide marker or TNF-alpha to measure the release of these compounds which cells produces, an amount of these compounds which cells produces. So obviously we also looked at the MTT assay as well, the cellular viability, and she normalized that compared to the control, as you can see here. So it did affect slightly cell viability, but it did not affect it because of our system. It's affected because we dropped pH. So cells were not very happy with the pH drop to 6 initially, but they recover after a few days. So, and that was all right afterwards. So this is still, it's short because it's still under development. Melissa is still doing experiments and working on optimization of her model. We wanted to demonstrate that using again LBL construct, you can have a sustainable release, not only anti-inflammatory, antimicrobial drugs, but also anti-inflammatory molecules, and can modulate inflammatory response accordingly. Also, of course, dexamethasone is not, it is toxic, but for the concentration which we use was not toxic. But we wanted to make sure that when we deliver it through LBL construct, of course, there is an increased amount of dexamethasone could be found. So we wanted to make sure what we release daily is not toxic, and this has been shown no toxicity. So it's still ongoing studies in progress, so we're developing that, and hopefully with time we will be able to show that in vivo as well. So this is just one last slide. Some ideas for the project. I mentioned already that we develop another system where you can deliver cancer drugs and to deliver effectively, specifically for the breast cancer. We're working now with a biologist from Cardiff, and I hope that we can have collaboration with Unicamp as well. So there is an interesting still nanotechnology with the base carrier systems for delivering novel antimicrobials. And I'm quite interested to expand the application of that to work with rare tropical infectious diseases as well. So if there is any interest from colleagues from Unicamp, I would welcome that. And again, we already work with Professor Karina and her colleagues in Prezicabo on delivering of effectively antimicrobials for dental bone cements. But again, if there is any interest to expand that towards other bone diseases such as osteoarthritis, I would be very happy to discuss that. So this is my funding, which fund my research group for the last 10 plus years. And this is my research group to date, and thank you for your attention. Obrigado.
Working. Yeah, now it's okay. Thank you, Polina, for your great presentation. It's open for questions. Is there anyone?
Hi, thank you, Polina. Oh my God, look at this. It's been a while since I don't use a microphone after the pandemics. So thank you for your presentation. Congratulations on your work. I was just curious about the polyplex. I think there are many questions, but I will focus here on, for example, on the layer-by-layer method. Did you evaluate some scale-up issues or anything related to a scale-up production of this kind of nanoparticle? And concerning the polyplex, did you evaluate the interference of the molecular weight? I do not know your molecule, so I don't know if you have different molecular weights or different cations that would make an effect on your results. Thank you.
Thank you. The first, I will answer to the first question first. Yes, we did perform scale-up production, but we started from small batches of nanoparticles, and now we're able to do, with the help of automatic layer-by-layer system, we're able to do, quite a lot of these nanoparticles. So, for example, with one batch, which we kind of prepare now, we were able to cover all the experiments from start to finish, starting from the material characterization towards the biological activity, which in the beginning we were not able to do it. We have to do more smaller batches at the time. So yes, that's easy to scale up. That's fine. And it's relatively, I have to mention that these polymers, they're relatively cheap to buy, so it's not impacted greatly on the cost of nanoparticles afterwards. In terms of molecular weight, yes, they vary. They're starting from 5,000 daltons to go towards 50,000 daltons. We did not find the effect in terms of release. Release does not affect on the molecular weight of the polymers, but the structure of the polymers affects on the molecular weight. Affects on a release. This is because of the principle which is layer-by-layer deposition adopts. So if it's a zeta potential, you see, if the zeta potential, if you have strong electrostatic interactions within the layer-by-layer construct, so it means your release will be for longer, and it's it's more stable construct as well. When you have very weak electrostatic interactions within the layer, so your release will be quite fast because constructs tends to break down much rapidly, as there are not strong forces within the layer-by-layer construct. So zeta potential has got great effect on the stability of the construct and on the release profile and the structure of the polymers as well.
Okay.
Hi, Polina. Thank you for your talk. I just want to ask, how did you perform the release study? It was like a dialysis bag.
We did release in PBS. We just put known weight of nanoparticles in a known volume of PBS, and every day we change the media so we can estimate the cumulative release later on, and we quantify it using HPLC.
Okay, thank you.
Welcome.
Anyone else? No? Polina, I would like to ask you about these nanoparticles. Do you think it's possible to use these nanoparticles for coating implants, for example, instead of using bone cement?
Not using nanoparticles for coating implants, but creating similar layer-by-layer construct on the surface of the implant using the same principle, but instead of coating the particle, you coat basically the flat surface. Yes, it's possible. We just need to functionalize. We did that. So this is the Melissa last studies which I showed you on dexamethasone, but there was another my PhD student which finished 2 years ago. So we published that. We did functionalized titanium implants, and we basically made layer by layer deposition on the top of the implant itself without nanoparticles.
You did this.
Yes. Yeah.
And do you know that it interferes on the surface of the implant, or like roughness, for example?
It's very insignificant because, in fact, implant is very rough.
Yes.
You know, if you think about the implant, and it's done on purpose, the coating which we create is just, you know, on a sub-micron levels. So it's much smaller compared to the roughness of the implant itself. So it does not really change the roughness of the implant.
Okay. And can I ask you something for the first part of your lecture? I was curious about the osteoarthritis model. Is ex vivo. What kind of animal? I don't remember if you told.
Young cow. Young cow.
Ah, young cow, yes. And it's used some media or buffer to study the permeation of the...
Yes, we did an herpes buffer because it's mostly simulating what you have like in synovial in terms of viscosity and the concentration of...
and you quantify by HPLC, or how did you get the sample?
Yes. Because we did quantification through HPLC as well. Is it a classical, you know, standard protocol of quantification, anti-inflammatory molecules using HPLC techniques? Yeah, all of this was quantified by HPLC.
So, if someone would like to ask, we have this opportunity. Polina, I think everybody, it's okay. If you're a lecturer, I would like all of us would like your to be here, and I will. I'm here. It's better. Thank you for being here. Share your knowledge with us, and we will spend a week together. But this moment is very important because you can share your knowledge, your study with the others. And Polina, as Polina said, she's open to partnership. So she put here her email, yeah. And I think it's okay.
Thank you very much.
Thank you very much.
Thank you very much, Karina. Thank you, everybody, as well, for attendance, for warm welcoming. This is my second visit of Unicamp, and I'm really very pleased to collaboration with Unicamp, to your welcoming, and I'm looking forward to continue existing collaborations and to open new collaborations, and thank you. Thank you.
So we can finish.